Good morning, good afternoon, and good evenings, everyone from all of the world. I'm so happy to see you again in the ACNS YNS webinars. So today our chair is Professor Tadashi Watanabe Sensei, who is the professor in Department of Neurosurgery, Aichi Medical University, the Ghibli in Aichi in Japan. So we have a slight change of our schedule. And we'll start with Dr. 𝒂𝒏𝒔 𝒂𝒑𝒂𝒂𝒂𝒂💏, who is the chair of the Young Neurosurgeons Committee of the European Association of Neurosurgical Societies, YNS. He is also the assistant professor of neurosurgery in Bowum Department, University of Messina in Italy. And our next speaker is from Whitman, who will present a giant schwannoma of the 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 And our expert speakers is Professor Sebastian Folisch, and who will be talking about the mini combined concept of procedure and combined control approach, and also Dr. Milena Peak will be talking about a young neurosurgeon's perspective or of parts in the management of chronic pain, who is the chief of Neurosurgical Center Clinical Hospital of Finland and president of Ukrainian Association of Neurosurgeons. He's also the associate professor of the Department of Neurosurgery of 𝒂𝒏𝒔 National Healthcare Universities. Our next discussant is Professor Kosetin, who is the professor in neurosurgery of the Department of Neurosurgery, the J.K. University School of Medicine in Tokyo in Japan. And to moderate the session with me, with Dr. Teek, Joey Sam, Dr. Skonawas, and also Sukiti. So without further delay, shall I invite our chair today, Watanabe Sensei, to chair our first session by Dr. Giovanni.
Okay. I am Tadashi Watanabe from Nagoya, Japan. And let me introduce Dr. Giovanni Raffa. He's the first speaker, and he's going to talk about modern strategy for pre-operative planning and surgery of brain tumors in eloquent areas. Okay. Will you start your lecture, please, Dr. Raffa?
Thank you so much, Professor Watanabe. Thank you, Ben, for the kind invitation. It's always a pleasure for me to be here with the friends of the ACNS. The topic of my talk will be, as you said, the modern surgical strategies for surgical resection of brain tumors, especially brain gliomas, located in eloquent areas, because we know all that the extent of resection is probably the most important independent predictor of survival in these patients, but also the Karnofsky performance scale, the postoperative KPS, is another important predictor. So if we want to successfully treat brain gliomas located in eloquent areas, our objective must be to achieve a maximal safe resection, thus trying to increase as much as possible the extent of resection and preserve the surrounding eloquent networks. For example, the motor network, the language networks. But we know today that the functional organization of this network inside the brain is very complex. So if we want to identify these networks and preserve them with surgery, we must use intraoperative neuromonitoring and, when feasible, also 𝒂𝒑 surgery to preserve motor, language, especially language, and also other cognitive functions. But today, Today we have also new technologies for performing a preoperative neurophysiological mapping of brain networks. So we can merge information from coming from neuroimaging, electrophysiology, and neuropsychology to perform also a preoperative brain mapping. So we can rely not only on intraoperative mapping and monitoring, but also on preoperative brain mapping. That can be feasible thanks to some new technologies like the navigated transcranial magnetic stimulation that is able to anticipate the intraoperative mapping findings. So we can achieve just before surgery a mapping of the motor cortex, of the language cortex, but also of other eloquent cortex. So the surgeon can enter the OR and just verify using intraoperative mapping the organization of these networks in order to preserve them. So today, thanks to the NTMS, we can anticipate findings of intraoperative mapping and monitoring. But what is NTMS? NTMS is a technique based on the induction of a magnetic field that is applied thanks to a magnetic coil over the scalp of our patient who is seated on a chair. Thanks to this magnetic field and electrical activation of the cortex below the coil is achieved, and that permits a focal manipulation of cortical activity. So we can use information provided by NTMS to achieve a preoperative brain cortical mapping. You can see here the navigated coil that is moved over the 3D reconstruction of the brain MRI scan of our patient. By doing this, we can identify, for example, the motor cortex and the relationship with the lesion. So we can use two different paradigms for stimulation, a single pulse stimulation in which we activate the cortex located below the coil, for example, the motor cortex, so we can achieve in this way a motor evoked potential, the same motor evoked potential that we can achieve intraoperatively using direct electrical stimulation. But and then in the end we can have a 3D reconstruction of the brain MRI of our patient with the somatotropic organization of the motor cortex. You can see different spots in different colors. Each color represents a different muscle and a different motor evoked potential that has been achieved by the preoperative NTMS mapping with a high spatial accuracy. But we can use also NTMS. Sorry for the audio. We can use the NTMS also for mapping, for example, language. In this case, the paradigm is different because we are using a repetitive stimulation that interfere with the brain activity during the execution of a task. So exactly as we do during a wax surgery, we ask the patient to perform a task, a neuropsychological test that can be also a simple object naming test, like in this case. And while the patient is performing the task, we try to interfere with the cortical activities by using repetitive TMS stimulation. If we are stimulating the cortical areas located in the language areas, the patient will commit an error, will perform, for example, a speech arrest. So that means that that spot that we are stimulating using the TMS is important for the language network. So we can visualize the cortical NTMS spots over the MRI scan of our patient, and we can plan a surgery trying to resect the lesion without resecting also the cortical areas which have been demonstrated to be eloquent for the language network. What is the accuracy of this kind of techniques? Several papers have been published, but in the end, I want to show this review that demonstrated that the NTMS is more accurate, for example, or of a widely diffused preoperative mapping methodology, that is functional MRI. So regarding motor mapping, NTMS is more accurate than functional MRI. And the accuracy of mapping is important because it allows to stratify patients before surgery. I want to show this case. These two slides come from the same cases. This low-grade glioma, frontoparietal glioma. If we want to identify the knob, so the central sulcus on the contralateral side, probably this is indicated by this red line. So probably on the affected side, the lesion is involving the motor cortex. But when we perform the NTMS electrophysiological mapping, you can see the motor cortex was just anterior to the tumor. So in this case, resection has an intermediate risk because lesion can be resected without touching the motor cortex. This is another very similar case. Again, low-grade glioma, frontoparietal. This is the hand knob on the contralateral side. So probably the lesion is located anterior to this central sulcus. But in the end, when we performed our NTMS mapping, you can see the lesion was infiltrating the motor cortex. So the risk for surgical resection in this case is very high. That is because we are not so good in interpreting the MRI scan, probably, especially because usually the identification of anatomical landmarks on preoperative MRI based only on anatomical information like the hand knob sign for the identification of the Rolandic fissure is not so easy. It depends also on the angulation of the MR acquisition. So using NTMS, it's possible to objectively identify the motor cortex because we register the motor evoked potential. But of course, we need also information about the subcortical structures, so we can perform an NTMS-based DTI tractography for the visualization of the corticospinal tract as we have performed in this study. We use the NTMS cortical map, a seating region for the reconstruction of the corticospinal tract, and we achieved also the somatotopic organization of different fiber bundles of the corticospinal tract, distinguishing between those directed to the cortical representation of face muscles, which are depicted in pink, those directed to the cortical representation of the arm in red, and those to the leg in green. And we also compared the efficacy or the accuracy of this kind of DTI tractography based on the NTMS finding as compared to standard tractography, which is based usually on anatomical landmarks. And we demonstrated that the NTMS-based approach is more accurate. And it can be used during surgery to guide also the intraoperative direct cortical and subcortical stimulation, thus increasing the confidence of the surgeon with the resection of the lesion when we are close to the corticospinal tract. This is very important. As you can see in this case, the lesion is quite anterior to the central sulcus, but if we look on the sagittal plane, the deepest portion of the lesion goes posteriorly, so probably it is involving the corticospinal tract. This is another case, recurrent glioblastoma, which can involve the motor cortex. So according to the MRI scan, the simple MRI scan, both cases are at high risk for postoperative motor deficits. But when we look at the preoperative planning based on NTMS-based reconstruction, we can see that the two cases are different, because in the first case on the left, the corticospinal tract is just displaced, while in the second case, the fibers of the corticospinal tract passed through the tumor. So the tumors infiltrated the corticospinal tract. It's easy to understand that in the second case, we probably cannot achieve a gross total resection, but we can try in the first case. So the risk is completely different. And this kind of planning is really efficient from a clinical point of view. We analyzed in this systematic review a few years ago the efficacy of the NTMS motor mapping and planning before surgery of motor eloquent lesion. And we demonstrated that according to the literature, the NTMS motor mapping and planning slightly reduce the occurrence of new postoperative permanent motor deficits as compared to standard surgery using only intraoperative mapping. And in the same study, we demonstrated also that using the NTMS preoperative mapping and planning, we can significantly increase the gross total resection rate, because the surgeon entering the OR with a higher confidence in the spatial relationship between the lesion and the corticospinal tract. What about language mapping? The evidence regarding language mapping are a little bit contrasting. So we can say that as compared to the functional MRI, NTMS seems to be more accurate even for language mapping with especially high negative predictive value. And in the end, this is a study published by the colleagues from Berlin, in which it is demonstrated that the NTMS mapping present a very good accuracy with a very low number of false negative spots. So the NTMS is really accurate in detecting language negative areas, exactly as it happens during surgery when we achieve a negative language mapping, as demonstrated by Sanai in 2008. Again, even for language, we need to reconstruct the subcortical tracts and the complex subcortical language network that is more complicated, more complex to visualize as compared to the corticospinal tract. And this kind of reconstruction is able to allows the neurosurgeon to stratify patients according to the distance between the lesion and the subcortical tracts. And in this study, we demonstrated that this kind of planning is also able to predict the occurrence of postoperative language deficits according to the distance between the lesion and the language network. So we use all this information provided by the NTMS preoperative mapping and planning to plan the best surgical strategy, try to understand the relationship between the lesion and the NTMS spots that here are depicted as white spots, and the subcortical language tracts computed using the NTMS-based tractography, like in this case, left temporal glioblastoma small but close to the language network. Then we use these informations, this preparative information, to stratify patients according to the distance between the tract. Like in the left, you can see the relationship between the lesion and the orange tract, that is the vertical segment of the arcuate fascicle, or in the right, you see the blue fibers, who are fibers of the IFOF and or of the UF, to distinguish between patients who are at high risk of postoperative deficits from those who are at an intermediate or low risk for postoperative language deficits. And then we use all this information to guide our intraoperative mapping, who is always mandatory, which is also always the gold standard. But by using all this information into our neuronavigation system, we can guide also the intraoperative cortical and subcortical mapping. So whenever we deal with a patient with a lesion with a brain glioma who is located in a suspected eloquent iris, we perform our NTMS-based mapping, cortical mapping and planning using the DTI tractography for the reconstruction of the entire network. And according to this kind of preoperative stratification, we decide if the patient must undergo a WEC surgery or a sleep surgery. And then we perform our surgery using all the NTMS information for guiding intraoperative mapping and monitoring. This is our series in 10 years, more than 440 lesions that has been treated using this kind of approach, mainly composed by high-grade gliomas and low-grade gliomas. I show you a few cases. This frontoparietal lesion on the right With the patient who had a left hemiparesis, the lesion seems to be in motor area. When we performed the NTMS mapping, we realized that the motor cortex was just pushed forward by the lesion. So the lesion was not infiltrating the motor cortex. So that means that we can try to achieve a gross total resection and preserve also the motor network. This is the 3D reconstruction of the relationship between the lesion and the corticospinal tract. And this is what we have done during surgery, using also sodium fluorescein to improve the visualization of the tumor. So we use our navigation to localize the NTMS cortical areas. We verify the motor cortex, and then we start with our resection. So we verify intraoperatively what we achieved preoperatively. Usually the NTMS mapping is very accurate. So once we verify the relationship between the tumor and the motor network, we can proceed performing our surgery up to achieve the gross total resection. This is postoperative MRI. This is another case with a language eloquent lesion. I show you before the video with the preoperative planning. This is the NTMS mapping showing that the NTMS spots for language cortical areas were surrounding the lesion but not overlapping to the lesion. And this is the 3D reconstruction of the whole network with the relationship between the lesion and each single fascicle of the language network. And we were able to operate the patient using a wet surgery, and we used all this information to guide our resection and our intraoperative stimulation. This is the postoperative MRI scan with a gross total resection, and we didn't experience any postoperative language deficits. But we have a problem. We have an elephant in the room because not all patients can be submitted to 𝒂𝒑 surgery. For example, children or patients with psychiatric disorders, or in some cases, is the patient who doesn't want to undergo 𝒂𝒑 surgery. In those cases, we can use just only our NTMS-based planning. So instead of going for a standard sleep surgery, we can perform a sleep surgery guided by, of course, the NTMS information. This is a paper that demonstrated that this kind of approach is useful in children. And I want to show this case in which a patient was not eligible for 𝒂𝒑 surgery because he was not cooperating. The lesion is close to the left temporoparietal junction. This is the 3D reconstruction of the network with the lesion that is close to the orange fibers that are the arcuate fascicle, especially the segment, the vertical segment. This is how we use this information intraoperatively, and this is the postoperative MRI on your right, in which we removed completely the lesion, and the vertical portion of the arcuate fascicle was completely preserved, and the patient has not postoperative language deficit. We analyzed all our series in those patients who were not eligible to undergo 𝒂𝒑 surgery and who were operated for brain tumors located in language eloquent areas using the NTMS planning. We enrolled 176 patients, and the final result that we achieved a postoperative permanent language deficit in 7.3% of cases. That is not so much higher than the percentage reported in the literature for 𝒂𝒑 surgery, but consider here we have patients with language eloquent lesions operating during asleep surgery using only NTMS information. And the gross total resection was 80%, but in those cases in which NTMS mapping showed that there was a safe distance between the lesion and the language network, the gross total resection was 100%. So I want to show you, I finished with this last slide that is probably provocative because probably we are facing a paradigm shift. We all know that we started understanding the function of a brain on post-mortem studies like did Paul Broca for the Broca areas for the language function. Then we continued with Penfield and with the study of the brain functions using intraoperative direct electrical stimulation, and this is still the gold standard for surgical resection of brain gliomas located in eloquent areas, especially close to the motor cortex. But probably we are moving to a new era in which preoperative mapping with TMS, for example, can anticipate these findings and can help us, especially in those patients in which for example, 𝑥 surgery is not feasible. So thank you so much for your attention.
Thank you, Dr. Rafa, about your fantastic technique, and really appreciate. Congratulations. And I was surprised, and I think it is really good for pre-operative study, especially for eloquent area gliomas. And is there any question from the audience? I think I found many dots on the images on the brain. So that may be the point you stimulated preoperatively. So, but there was many dots. So yeah, how long does it take for the examination for one patient, one surgery?
But a standard examination can last about 20 minutes, but in the end, it depends on the location of the tumor. If we suspect that it's very close, we try to increase the number of spots, so the duration of the length of the procedure is higher. If we want just to verify that we are at a safe distance, we can do a standard mapping just to be sure that we are far from the motor cortex, and it can last also even 10-15 minutes.
Yes, a really short time.
Yeah, it's not that long. We changed completely our way to approach to these patients, because now every time we have some doubt, we perform the mapping. So in 15-20 minutes, we have already our preoperative mapping. We are more confident in approaching this kind of tumors.
Thank you. Any question? Other question? Dr. Ben?
Yes, Giovanni, it's nice to hear your lectures again. And I have another questions. I asked some of the questions in your previous presentations, and but I think I have a question that what if you find that your the POP the navigational TMS the result is different from the intraoperative mapping? So what would you do?
I've said that the intraoperative mapping is the gold standard, and we rely on intraoperative mapping. That's obvious. We just verify if there is a difference. Of course, we rely on intraoperative mapping. We use the preoperative mapping just to have an idea and to be more confident with the relationship between the tumor and the network that we want to preserve before entering the UR. But once we enter in the UR, we perform the intraoperative mapping for motor eloquent lesion. In case of language, in patients who are not eligible for awake surgery, we have nothing to compare with, because the patient is asleep. So in those cases, we rely on the NTMS mapping findings, just on that.
Yes, but I would like to maybe I put my question in another way. So let's say if your the function the navigation MRI has a positive mapping, but in case the intra-off mapping is negative, so how would you increase the stimulation? So let's say the navigational MRI is positive, but intra-op is still negative. How much would you increase the stimulation to say that okay, maybe the navigational TMS might not be correct.
In those cases, we increase the intensity of stimulation. For example, if we are at a subcortical level, we try to increase by 1 milliampere. And if we have no responses if we achieve a response at the distance that is higher from 5 milliamperes, we can go on until we reach a response at 5 milliampere. So in the end, it's always intraoperative mapping that guide our resection. Probably, but I will say and show to you that there are several studies that demonstrated that for model mapping, the NTMS is really accurate because it's a methodology which is based on electrophysiology. It's totally different as compared to functional MRI. Functional MRI is the analysis of a signal derived from the MRI acquisition. It depends on the blood oxygenation. So that can be really inaccurate as compared to NTMS, because NTMS is an electrophysiological techniques, exactly the same of the direct intraoperative electrical stimulation. So the technique is the same. So it's difficult to have different results, especially for model mapping.
I see. Thank you so much, Giovanni. And I can also see that Professor Sebastian Forrest has just logged in, and is hello, Professor Forrest.
Hello.
Nice to see
Hello,
you.
everyone.
Nice to see you again.
Sorry
Thank you
for
so
being
much.
late, but I thought it was 12 p.m., so I was ready to stay awake late.
Thank you so much for joining. So we have just finished Giovanni's lecture, and maybe we can go ahead with your lectures after the discussion of Giovanni's lectures. Is that okay?
Okay.
Yeah,
Okay.
absolutely perfect.
Okay.
Absolutely perfect. Do you see my slides?
Yes, we can.
Yes. The chair of today is Professor Watanabe Sensei from Japan.
Hi, hello. Hi, nice to meet you again.
Very nice to see you. Very nice to see you.
Okay.
So thank you very much for the opportunity to discuss about combined petrosal and our late refinement of the technique, which is what we have called the mini combined petrosal approach. So I will discuss the concept of combined petrosal and then show you how we try to minimize as much as possible this approach. So I like transpetrosal approach because when you look at these pictures of the skull base from below, you understand that if you follow the concept of skull base surgery, which is to take out bone in order to avoid brain retraction, if you follow the petrous bone, well, you can get to the central skull base, basal cistern, without much retraction of the bone. Everything starts with the posterior petrosal approach. And the posterior petrosal approach concept is that it's a looking up approach. It's absolutely key to understand that the line of sight should go below the temporal lobe through the mastoid process, below the labyrinth, to get to the target. If you use a good concept of the posterior petrosal, which is really this line of sight that goes from down up, lateral to medial, posterior to anterior, you don't need much temporal lobe retraction. But this is based also on another thing, which is key for posterior petrosal approach, is the control of the sigmoid sinus transverse sinus junction. This comes from Almefti, which also come from obviously Akuba and Osaka school, controlling the sinus, which means controlling the dura in front of the sinus, controlling the temporal basal dura, being able to cut the superior pectoral sinus and the tent, allow you to do that transposition of the sinus posteriorly, inferiorly, and to create this corridor, this looking up corridor behind the labyrinth, again, going from inferior to superior, posterior to anterior, lateral to medial. We are not using for this approach the corridor provided by the drilling of the mastoid. We use the corridor created by the transposition of the sinus, which is only possible if you get the control of the pressing dura. So on this cartoon, you can understand this even better. This is here the brain, and this is the transposition of the sinus, and this creates this line of sight that goes behind the labyrinth, below the temporal lobe, towards the central system, and especially the retroinfundibular space. So if you follow this concept, in fact, you don't really need to retract the temporal lobe. I like to compare the posterior petrosal concept with the frontotemporal approach because, in fact, it's exactly the same. When you do a frontotemporal approach, you do a frontotemporal craniotomy. When you do posterior petrosal, you do temporal-occipital craniotomy. In one side, you work between frontal lobe and temporal lobe. For the posterior petrosal, you work between temporal lobe and cerebellum. With frontotemporal approach, you focus your approach in the sphenoid ridge. You drill the sphenoid ridge as much as possible, preserving the orbit and periorbita. For the posterior petrosal, you focus on the petrous ridge, you drill the petrous ridge, you preserve the labyrinth just as you preserve the orbit and periorbita. You work along the orbit on one side, you work along the labyrinth. And at the end of the surgery, if you want to gain additional space, if you want to gain additional line of sight, you can drill the anterior clinoid process, which is the tip of the sphenoid ridge, or you can drill the petrous apex, which is the tip of the petrous ridge. If you look at those two pictures, it's on one side on FTOZ approach, a frontotemporal approach with complete removal of the superior and lateral wall of the orbit, and the other picture is a combined petrosal approach. And you see that it's really similar in terms of structure exposed. On one side, again, you take advantage of the sphenoid ridge. On the other side, you take advantage of the petrous ridge, and you work between cerebellum and temporal lobe. So the posterior petrosal approach, sometimes I use it alone, which means I am not using an anterior petrosal approach also. I use a pure posterior petrosal approach when there is no need for the line of sight offered by the anterior petrosectomy. When I, for example, don't need to devascularize the tumor base, like in petroclival meningioma, or when I don't need to open Meckel's cave in giant trigeminal schwannoma or in petroclival meningioma. When I add the anterior petrosectomy on anterior petrosal approach, then you get the combined petrosal. But what's important to understand with the anterior petrosal approach is that it gives you an additional line of sight, which is a looking down line of sight. The anterior petrosal is not made to look up, because if you want to look up with an anterior petrosal, you need to retract the temporal lobe much more. If you want to look up, you use a posterior petrosal running below the temporal lobe without a need for retraction of the temporal lobe. So the combined petrosal offer, and that's the beauty of this approach for a big tumor, it offers multiple line of sight. You can look at the target, at the tumor from different perspectives. And there is an optimum perspective for each critical structure you have to separate from the tumor, each cranial nerve. There is an optimal perspective for dissecting the tumor away from 7 and 8. There is an optimal perspective to dissect the tumor away from 5 or from 6. And there is an optimum perspective to dissect the tumor away from the basilar. So this multiple line of sight, to me, is really the beauty of this approach. So my indication, it's a large or giant petroclival meningioma for small or mid-sized tumor, or even for those which are more tentorial type of petroclival, I use RetroSig approach, which is perfect for this. But for large or giant ones, which are really deep, really clival type of petroclival with the cranial nerve pushed laterally, I like this approach. I use it sometimes for chordoma, sometimes for chondrosarc, large ones, sometimes for giant epidermoid cyst, and sometimes also for big third or fourth nerve schwannoma, which are quite rare. For meningioma, the other advantage, in addition to this multiple line of sight, is that you get to the tumor base first. So you devascularize the tumor first, and it's a key concept for meningioma in general, convexity or skull base. But skull-based meningioma can be transformed in kind of convexity meningioma if you expose the tumor base first and you control the feeders. Those approaches are complex because you have to deal with this complex anatomy of the skull base, normal anatomy of the skull base on petrous bone. But we have a big advantage is that imaging study, simple imaging study like CT scan can give you everything you need to anticipate the potential complication or risk of this extensive drilling, because you can figure out where are the structures, what are the variation, are the structure uncovered by bone at some point, like the superior semicircular canal, the carotid artery, or the geniculate ganglion. You can spend time before the surgery looking at this and be ready when you start. And this is much better than navigation. It doesn't mean that navigation is not useful, but it means that navigation do not replace watching carefully at all the details of this anatomy before to be prepared. And we published this article a few years ago emphasizing the importance of looking at this before the surgery. So this is example, looking at this is key. You understand here that the approach is done by pneumatization, and you know where to stop if you look at this carefully. Once you see this cancellous, this cortical bone surrounding the semicircular canal, you know that you cannot drill anymore. Here, when you want to do a cosmetic mastoidectomy, which means keeping the cortical bone of the mastoid process intact, you understand that you have to look at this junction between sigmoid sinus and transverse sinus, because sometimes it's very close to the surface. So if you take your chisel or B1 to separate this cortical bone of the mastoid from the air cells, you can easily injure the sinus. The same for MRI. MRI, you have to look at every details of the characteristic of the tumor with CIS sequences or Fiesta sequences, 3D T2. You can locate the nerve most often. You can understand their trajectory. You may not be able to see it, the nerve itself, but you know where it goes when it goes out from the brainstem. And this is extremely precious indication for the surgery. For those type of approach, venous consideration are key because, as I said at the beginning, we will have to mobilize the sinus. But the sinus itself is not the most important. The most important is the veins draining into this sinus. Vein of Labbé, petrosal vein complex, but also the superficial and deep middle cerebral vein, which may be modified by the tumor. Especially if the deep middle cerebral vein drain, for example, in foramen or rotundum or foramen valley, it's important to know it, because when you do an anterior petrosal approach, you can sacrifice this vein because you have to peel the dura from V3. So all this need to be carefully and thoughtfully anticipated. So this is a concept. Now about the technique itself. The technique itself, the mini combined transpetrosal, is based on the same concept. The only thing we try to do is to create a more targeted approach, to drill only what we need to drill for a specific target, to mobilize the soft tissue in a way that it doesn't bring additional morbidity to the patient. It's already extremely complex surgery, and there is no need to take risk with the frontal branch of the facial nerve, to take risk of having a temporalis muscle atrophy. So all this should be also carefully managed during the surgery, and this is also the concept of the mini combine. We were not the first thinking of reducing the aggressiveness of the approach. Takeo Goto from Osaka has published this article, which inspired us also in a way to try to do the same with a slightly different technique, but to do only what's necessary for a specific target. My skull-based fellow working with me now, Arianna Fava, from Italy, published this article in 2022. A great article to explain this concept. So here you see the different type of incisions that can be used for combined petrosal approach. And the one we use is this one, this green incision, question mark incision, starting at the tip of the mastoid and turning around the ear. It's a quite small incision. We don't have a big skin flap. We only elevate what we need to provide a sufficient exposure. So once the temporalis muscle is retracted with a subperiostal dissection, retrograde dissection to keep the deep periosteum intact, we push it anteriorly and also superiorly to expose the root of the zygoma. We peel also the muscle, nuchal muscle from the mastoid, but we don't go through the muscle. The same, we try to be subperiostal to preserve the periosteum deep to the muscle, which is a protection for vessel and nerve most often. This is the sinus here. We make next a big burr hole on the transverse sinus. We want to expose the sinus, but even more, we want to expose the dura below, posterior fossa dura, and the temporal fossa dura above. We do most often an additional burr hole here in the temporal fossa to elevate the dura carefully from the bone. And then we do this craniotomy. We do it quite often one piece, but this is absolutely irrelevant. It's just easier for reconstruction. But if you believe that you take any additional risk for the sinus trying to do it one piece, just do it two piece or three piece, whatever it needs to preserve the sinus. This is how it looks once we have taken out the bone flap. And then we do a cosmetic mastoidectomy, which means we preserve this cortical bone for cosmetic reason. It's important because otherwise the patient may feel a big hole behind the ear, and sometimes there is asymmetry of the ear. This is a cosmetic mastoidectomy. We do a groove and then we finish with chisel. Once you have exposed completely the mastoid, you just have to drill those hair cells. At this specific point, before starting the petrosal drilling, we drain CSF. We drain CSF in two ways. Most often with a retrosig incision to go to the lower cranial cistern. This is what I prefer. But I have to say the lumbar drain here could be a great value. We are not using it much, but listening to Takeo Goto, I think I will change the technique and put a lumbar drain here instead of doing this additional incision retrosig. And you drain 30, 40 cc's of CSF, not too rapidly, but once the bone flap is away, it's fine because you don't risk to create too much hypotension. And you drain CSF to relax the brain, and this will help to elevate, to peel the dura from the temporal fossa floor, from the posterior fossa, the posterior surface of the petrous bone. Then you start to drill. You drill those hair cells, you make them communicate, but what you want to focus on is the petrous ridge. You see here, it's like looking at a sphenoid ridge, in fact. It's not so different. It looks exactly the same during the surgery. Most difficult is to shave the sinus and to take the bone over the sinus. I shave with 4 or 5 millimeter pure diamond, and then I take the remnant of bone with a round tip ronger. And what you need is really a targeted drilling. You need only, in fact, to expose the superior semicircular canal and the posterior canal. The lateral canal, opening the middle ear, finding the short arm of the uncus to find the facial nerve, exposing the facial nerve inferiorly is not needed in the vast majority of cases. The only reason why I drill and I shave the mastoid segment of the facial nerve is when I need the infralabyrinthine corridor. But this, it's just for specifically targeting the inferior clivus or the lower cranial nerve. But in most cases, as I said before, this approach is made to look up, not to look down. So this is how it looks once the bone drilling is made. You have here the superior semicircular canal, the posterior semicircular canal, and now we can start to work on the dura. One additional thing that is important is the endolymphatic sac. The endolymphatic sac acts as a fold that don't allow you to peel the posterior fossa dura from the posterior surface of petrous bone. Exactly like the orbitotemporal periostal fold don't allow you to peel the dura from the lateral aspect of the clinoid process. So we have to do something with the endolymphatic sac. And we have developed a technique. This is a technique published that is in process to be published by Tancredo Alcantara. He was a research fellow in our lab. To manage this endolymphatic sac. In fact, we peel the posterior fossa dura from the wall of the endolymphatic sac as it is shown here. You don't need to sacrifice it. You just need to peel the dura from the endolymphatic sac, just like you peel the lateral wall of the cameral sinus from the medial wall of the cameral sinus. And this allows you to be able to retract more this dura from the posterior fossa of the petrous bone. As I said, I drill only the facial nerve if I need to work on this infralabyrinthine corridor. But this is defined by the pathology, not by the technique. At the end, once I have done the anterior petrosal approach, I sometimes add the anterior petrosectomy, as I said before, in the vast majority of cases for petroclival meningioma, and this is drilling the petrous apex. So this is a view after posterior petrosal approach. You drill what you need. This is Kawase triangle. You drill premeatal, you drill suprameatal, you drill postmeatal, you drill also the true petrous apex below Meckel's cave if needed, and this is a final view of this line of sight through the anterior petrosal approach. In case patients have hearing loss before the surgery, well, you can drill the labyrinth. There is no need to keep the labyrinth. It gives you much more exposure if you drill the labyrinth. Dura opening, it's I do a temporal opening like this parallel to the superior pectoral sinus, but most important is to open the dura here above the transverse sinus, being careful with vein of Labé. Because if you don't do that, you cannot push down the transverse sinus. You can only push backward the superior sinus. I do also an incision here on the posterior fossa dura 𝒂𝒏𝒔. I go around the superior canal below superior pectoral sinus, and then I move downward in my anterior petrosal corridor towards the inferior pectoral sinus. And then I cut the superior pectoral sinus. I cut it as medial as possible to preserve the petrosal vein complex. And then you can push everything backward once you have cut the tentorium. And this is a final exposure working between temporal lobe, between cerebellum. Tentorial resection is the final step, mostly in case of petroclival meningioma. In case of petroclival meningioma, most of those tumors have a relationship, tight relationship with the tentorium. Sometimes it arises from the tentorium. So if you cut the tentorium, if you resect the tentorium, you open a window on the tumor and you devascularize also. So this is also key for petroclival meningioma. Closure, I try not to open the antrum too much, just what I need, because like this, I can close more easily. I put a thin layer of bone wax everywhere on the petrous bone, not too much. You don't want to plug the petrous bone with bone wax. And then I put a layer of pericranium and fibrin glue. I reapproximate the dura, and then I put pieces of fat. Risk of drawbacks, venous infarct, not careful with the vein, superior sigmoid sinus venous thrombosis, we have 10%. None of them were symptomatic, but still we have thrombosis, so you have to be careful when you drill, not too much heat. Temporal lobe retraction is an issue, but if you follow the good concept, you don't need temporal lobe retraction. I'm not using retractor anymore. Facial nerve palsy, force nerve, hearing loss, CSF leak are definitely issues. This is a case to finish, showing you this petroclival type of meningioma. It was radiation-induced meningioma, and it was growing after radiosurgery. So quite a challenging case for which surgery was the only option because she had already too much radiation. So here you see that I am trying to preserve the soft tissue as much as possible. This is a cosmetic mastoidectomy here. I am shaving here the sinus. I'm going now to the petrous apex. You see that I have not done yet with the posterior petrosal. I first want to isolate the petrous apex and do my anterior petrosectomy. And then I come back to look only for posterior sinus, posterior semicircular canal and superior semicircular canal. And now I drill behind as much as I can. And this is the opening of the dura. Here, the posterior fossa opening all around the superior canal. I am opening Meckel's cave here. This is the anterior cut and now the posterior cut or reverse to resect the tentorium. And then once you have done that, resected the tent, you see that you have a beautiful exposure on the tumor. Hopefully it was quite soft here, but still it was challenging because all the perforators were inside, and it was quite a challenging case to preserve all those vessels. I did it. I had no issues with cranial nerve and vessels. Patient outcome was great in terms of cranial nerve, but she had a little stroke, and I will show you the post-op images. At the end, there was also some tumors above the diaphragma sella that I could not reach with the microscope. So here I put the endoscope inside, and you see I am in front of pituitary stalk. I'm sucking this tumor. This is a post-operative, the closure. And this is here the post-operative MRI. You see that there is a tiny stroke here at the anterior aspect of the thalamus. So she was epiparetic. She recovered well, and she had also some speech issue. She recovered well, but not completely. Chondrosarcoma is also cases for which, I'm sorry, this is already the post-op images. This is a chondrosarcoma in an Ollier disease. It was a pure stone. This tumor was like ivory. Cannot take this out through the nose. I have tried in patients with those very hard chondrosarcoma, and in fact, you cannot take much. So in this case, to me, it was a perfect indication for this combined petrosal, mini-combined petrosal approach. So here is skin incision, the same. This patient was particular because there was a very limited pneumatization of the mastoid. So this is the opening, but you see here that I had a hard time keeping the cortical bone, but we did it. And here, look at this. It looks like a sphenoid ridge, exactly the same. And I am really targeting my drilling to what I need. I am going here to the petrous apex first, and then I come back to superior canal, posterior canal, and that's it. I have no need to take anything else. I drill more of Kawase. I deal with this endolymphatic sac like I showed you before. I don't cut it, I don't sacrifice it, I stitch it to retract it anteriorly. And that's about it for the approach. I work a little bit more on the petrous ridge. Here I deal with the nerves. There was this vein, there was this veins going into the tentorium that I try to preserve. So I peel the tentorium from the vein. And here is the same, cut the tentorium, this is force. And here start the real fight, because this tumor, as I said, was like stone, and I had to drill it. I drilled the vast majority of this tumor, which was the first time I had to do that in such a chondrosarcoma. It was really like drilling a piece of bone. But this piece of bone was unfortunately growing and producing a visual deficit, slow, progressive visual deficit, but clear visual deficit in a young patient. So I had no choice to go. At the end, she was fine. She had a 6 nerve palsy. I was absolutely unable to find 6 into this tumor. It was going into it, and I didn't even saw it. I just saw at the end that the nerve was going into the lesion, but I could not find it into it. So she had a 6, but she will have some oculoplastic surgery for this, and the results are quite good. At the end of the surgery, resection was quite fine. I didn't took everything out because it was too difficult. I left pieces. My goal was to decompress the vision and also the brainstem. And this is the post-operative MRI showing you that the decompression is not bad. There is still a little bit of lesion in the clival depression, but if it grows, we will use proton beam therapy. This was a case of chordoma that we treated first endonasally to take the extradural part of it through the nose. And for the second part of the tumor, which was extensive intradurally, and I didn't want it to take the risk for the cranial nerve going through the nose, I did a combined petrosal approach. I skipped the first stage endonasally, where I used my classic technique, chopsticks, one nostril technique, but this is here the same, the mini combine. You can see that soft tissue manipulation is quite limited. I think it was our first case, this one of mini combine, cosmetic mastoidectomy, the shaving of the sigmoid sinus. Here I was still a little bit too extensive with the drilling. Here you see I'm looking for fascial, but this was the initial surgery when we started with this new, trying to minimize the approach. Now I have to say I'm not shaving the fascial nerve anymore. And here is the anterior petrosal approach. I go a little bit faster because I am a little bit too long. But this is the end. This is the opening of the dura here. I ligate the sinus. It's not a petroclival, so here definitely I try to preserve superior petrosal sinus and the drainage of the superior petrosal complex. I was quite happy to use my 2-pancet technique to separate the tumor from the critical structures. It was soft, but not as I would have expected. It was a little bit more fibrous than expected. So another reason to be happy to come from transcranially and not from the nose. And here, this is the end. I want to show you this image here. This image is very nice because it illustrates the concept of looking up. I am looking at the floor of the third ventricle with mammillary body without retraction of the temporal lobe coming through this mastoid corridor created by the transposition of the sinus. Not so different from the vision we have if we put an endoscope through the nose. And this was here the final closure. Final closure, I put a piece of pericranium to make sure that there will not be any leak with the previous corridor through the nose. So this combined petrosal approach for me is a key approach for petroclival and clival lesion. If you have it in your armamentarium, I think it's extremely useful for some lesion. If you only have endoscopic endonasal, it's not enough. Some lesion needs to be treated through this corridor. It's understanding the concept behind it is key. I have seen people doing posterior petrosal approach with a significant retraction of the temporal lobe. This means that they have not understood the concept. And I advise you to go back to Akuba Al-Mefti publication, initial publication, because vast majority of what I have said today has been said already in the good article. And training in the lab is key, obviously. This is what I have done, and this is what I try to favor in the young guys who want to do skull-base surgery. Thank you very much.
Sensei, you're unmuted.
Thank you, Professor Fraulich. Thank you for the beautiful dissection. And it is really understandable when you compare the front temporal approach. Only we have to do is drill the ridge between the two brains. And I was really impressed. And but I think this technique is based on the real understanding of anatomy and of course the technique, surgical technique. And but I think I know you are the good endoscopic surgeon also. So in my opinion, I agree the huge meningeoma extending deep into the clivus and like a chondrosarcoma you showed, that may be the good case for your approach. But I think most of the cases arising from the petrosal bone or a tentorium, I think it is possible to approach from a retrosigmoid with an endoscope assist. I mean, actually, we do an exoscopic and endoscopic approach for such a kind of lesions. I would like to ask you about the retrosigmoid endoscopic approach. How about?
You're absolutely right, and this is definitely what I do. But today it was on transpetrosal.
Okay,
so.
Okay.
But this is also what I do. Like you, I guess there is many of those petroclival that can be reached through a RetroSig approach. It's a beautiful approach. It's the only approach that exposes from down up to the third nerve, down to the lower cranial nerve. So yes, it's a beautiful approach. I think there is good indication for one, good indication for the other. The one for which I use RetroSig are the tentorial type, 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 especially the tentorial type, 5 is pushed down. So you have a huge corridor above 5. The one for which I use a combine is where it's a true Clival type or Petroclival type, where you have a small window between 7 on 8 and 5 above, or 7 on 8 and 9, 10, 11 to work on this tumor. For those, it's better to have another angle to avoid working between those cranial nerves. The issue is that it's not always easy to know where are the lower cranial nerves, 7 on 8 and 5, especially if the tumor is big. And that's for the big tumors that I use this combine. For mid-size tumor, I definitely not use it. But you have to try to look at the epicenter of the lesion. Where are the calcification? Where are the trabeculation of the meningioma going to? Where it focus? And if you know where it came from, you can have an idea of where the nerve were pushed and anticipate what you will have in terms of space to work if you use RetroSig. But I totally agree with you. RetroSig should come first as a choice. But if you feel that it may be difficult with RetroSig, transpetrosal is an option. About the endoscope, yes, I use it. Endoscopic assisted microsurgery, I use it in almost all of my skull-based cases. At some point, I put the endoscope inside to look around the corner. This is the key concept of endoscopy, and to take with an endoscope what I was unable to take out with a microscope.
Thank you. There are some questions. Dr. 𝒑𝒏𝒔, please.
Yeah, Sensei, thank you for the opportunity. It was a very excellent presentation. Just two questions. Number one is in combined petrosal approach, at one point I have to cut the SPS, superior petrosal sinus. As we know, the superior petrosal sinus drain at the junction of transverse sinus and the sigmoid sinus. So what should be the distance from the junction to cut the SPS? This is number one question. And number two question, as you have already discussed, the comparative study between the combined petrosal approach and the endoscopic keyhole approach. What is the distinction between these two approaches?
So for your first question, there is no rules for this, because first there is variation. In the vast majority of cases, the superior petrosal vein complex drain to the sigmoid sinus, transverse sinus, because the distal part of the superior petrosal sinus is non-existent or is very weak. But there is 5% of cases where the lateral part of the sinus is very weak. So the superior petrosal vein drain into the cavernous sinus. So the conclusion for this is that every time you can keep the drainage of those veins towards superior transverse sinus, sigmoid sinus is better. So I try to keep in front to cut in front of the superior petrosal vein complex, except in non-petroclival case for chordoma, chondrosarcoma, where I see on the MRI that the lateral aspect of superior petrosal sinus is very weak. And in those cases, you have to cut behind. But this is a rare situation. But preserving veins should be the goal. Drilling the petrous bone is easy. Cutting the dura is easy. What's difficult in combined petrosal approach is to keep the sinus intact, to keep the vein intact. And if you start to sacrifice vein for no good reason, you always have another vein after that you will have to preserve this time for a good reason. But all this is connected. So every time you can, you should preserve the vein. We know this from the Japanese teams. They are the champion for preserving the veins for many, many years. And I think they are absolutely right. It's key for those extensive approach who expose a lot of veins. For your second question, it was about keyhole. It's two completely different concepts. I use keyhole a lot. I use eyebrow incision for tuberculum cellae, planum, olfactory groove. But I use also FTOZ. I use 𝒔 keyhole. I do a burr hole, €1 size burr hole for MVD. But I use also combined petrosal. With FTOZ combined petrosal, multiple line of sight. You can look at me here from multiple direction. With a keyhole, it's only one direction. So you cannot see behind except if you use an angle scope. But you need also angle instruments. So this depends on the size, location of the tumor, and the critical structure you want to preserve, and how you want to look at those. So there is place and rooms for every technique.
Thank you, Sensei. Thank you.
Ben, do you have some question?
Yes. First of all, thank you so much, Professor Fordish, and nice to learn from you again. You are a huge influence on me after in skull-based surgery after ICAT training that organized by you. And thank you so much to join us here in ACNS YNS webinars. So in our unit, we are actually following your footstep. I have two questions. The first one is already raised by Professor Watanabe about the 𝒂𝒐 with exoscope and endoscope. In our unit, we are using it more and more. And not only a 𝒂𝒐 is called a 𝒐𝒕, supracerebellar infertentorial, and with the cutting of the tentorium with the 𝒂𝒐 corridor. And I would like to ask about, because we are also learning your chopstick technique in endoscope. So in your endoscopic 𝒂𝒐 approach or 𝒐𝒕, and do you use a chopstick technique, or do you use an endoscopic holder, or do you ask your assistant to hold it? And my second question is about the mini combined petrosectomy. In our unit, we also are following your article to do this approach. But if the labyrinth is not drilled, then is there any tips that you reach the very anterior point of the pitcher's apex? Because sometimes the angle of sight and might be obscure with the labyrinth. And so what is your tips on this? Thank you, Professor Fordish.
Thanks for your question. So for the first question about 𝒂𝒑 and the use of the endoscope, I use the chopsticks. Yes, I use the chopsticks technique. I'm not asking someone to hold the endoscope or use a holder. And the way I use the chopsticks is in the nose. The chopsticks is easy because the instruments are held by the nasal vestibule. So I recreate a nostril around my approach, 𝒂𝒑. I put sponges around, wet sponges. So like this, my endoscope and the rotative malleable section can be supported by those sponges. Because yes, the chopsticks technique, you use the endoscope like this, and you use those fingers to manipulate the section, rotation. But if you need to carry the endoscope, then you need to close those fingers to carry it. So you need a support to free those fingers. And I do that with wet sponges all around. Like this, my endoscope is supported by the sponges. It works quite well. I am quite satisfied with it. So I advise you to try it. It's nice, but key is to have a malleable rotative section. It works with a straight section, but having a malleable rotative, it makes it easier. Exoscope. You talked about exoscope. I tried recently because one of my new fellow Nobuyuki Watanabe, he told me, "Oh, we are doing all this now with the exoscope." So I tried. I have to say I have difficulties. So maybe it's for you guys and not for me anymore to shift to the exoscope, or it needs to come in a better ergonomic ways, or maybe I have not tried the good equipment. I'm trying because you guys are pushing me to try, but until now I have to say I have difficulties. For your second question, it was, I'm sorry, I forgot.
about the during the most anterior part of the pictures apex
Yes.
in the mid.
Yes, I got it. Well, the technique we have published in ACTA is not completely up to date because we have changed. You know, it was the beginning of experience and we have changed it a little. So now I have to say that what I was not doing initially and what I do now is to drain CSF before starting the drilling. And this I learned it from Takeo Goto, and it's very smart. You have to drain CSF because if you drain CSF a lot, then you can peel the dura more easily from the bone and you gain a lot of space. So this is what I do now. So working on a relaxed brain, you can much more easily peel the temporal fossa dura to expose Kawase, and you create a better corridor between superior semicircular canal and the temporal dura to work. Because yes, with this technique, you have a more posterior to anterior line of sight than with the classic technique of anterior petrosal approach. Then it depends on for which indication you use it. For petroclival meningioma, it's more important to drill the true petrous apex below Meckel's cave than to drill the postmeatal triangle, because that's where are the feeders. That's where is the tumor base. So for this, the mini combine is great. If you have to drill the postmeatal space specifically, it's a little bit more tricky to have the good angulation for it. But I changed the order. I don't know if you saw in my videos that I've changed the order of drilling. I start with the posterior petrosal drilling, and then I move to drill the petrous apex, and then I come back. So you have to find your own way. What is most important is not to consider that there is posterior petrosal, anterior petrosal. It's not one after the other. There is only drilling the petrous ridge. That's the goal. The goal is not posterior and then anterior. The goal is the middle, the voice of the middle.
Yes, thank you so much, and thank you for mentioning about the 𝒁𝒂𝒂𝒂𝒂𝒂𝒂, where you are the first one who introduced these instruments in our unit, and we kept your first. We're in Queen Elizabeth Hospital in Hong Kong, and we kept the 𝒁𝒂𝒂𝒂𝒂𝒂 and we are using it in every transrenal surgery since then. Thank you.
I'm very happy. Thank you very much.
Okay. Dr. Rafa, do you have some question?
Yes. Again, congratulations, Professor Friedrich, for your outstanding presentation. It's always a pleasure to listen to your talk. And I want to ask you a simple question from the point of view of a young neurosurgeon. How long should be the learning curve to manage this kind of approach for a young neurosurgeon? What could you suggest to learn this approach to a young neurosurgeon?
Well, I spend time in a lab, so that's definitely something important. I think if you want to, to push those techniques, you need to spend time in a lab, in a skull-based lab. I spend more than 1 year doing this every day. And I was young. I was at the 3rd or 4th years of residency. And so lab is important. Courses is not enough. Going to courses and, 1, 2, 3 courses do not replace a lab experience. So that's my first advice. And then about the learning curve, it's forever. It never stops. Until we stop, I think the learning curve is, and when you feel that the learning curve is going this way, it's probably time to stop. That's my feeling.
Thank you so much.
Sensei, may I ask something?
Yeah, maybe Professor Lisang, comments from you.
Okay.
Please.
Yes. Thank you, Professor Friedrich. Thank you very much for great presentation as usual. It's my pleasure to hear it. Today I have a role of the discussing, so I have to discuss and comment. It's quite difficult, but my comment is to the presentation you you showed us, actually it's a next step in developing of petrosal approaches, which was started from trans-petrosal with resection, then from anterior, posterior, 𝒂𝒏𝒔 and posterior petrosal approaches. Actually, I accept your idea. So what you do, you tailor the approach according to specific situation in the wound. So if you need more anterior petrosal, you drill out, you provide this access. Then you accomplish it with the 𝒂𝒏𝒔 route to the ventral surface of the brainstem. And then if you need, you can go up via the petrosal ridge to the retrochiasmatic area. So thank you very much. That's for this idea of tailoring. First of all, of course, you plan it, but anyway, I understand that we must tailor approach according to the situation in the wound, every situation. In my practice, I'm quite conservative. I do trans-petrosal approaches, but when I analyze in the patient, I consider from opposite. I think how can I avoid this complex approach? Because agree with me, it's quite complex and associated with a bit level of complication. According to the latest meta-analysis, it's 8.5 up to 10% accumulated. And what in your practice, my question is, in your practice, how much you can replace this approach by using of 𝒏𝒔 for combined petrosal with which when you operate on the petroclival region, and how much can you use the transnasal approach for especially for retrochiasmal area? How much it could be replaced by this more simple, shorter, and which the approach with less level of complications? This is maybe you can comment it.
Yes, no, it's a very good remark, and an extremely important remarks. And I agree with you. If you don't feel confident enough, it's an approach to avoid. But to be confident, you need to do it often. So it's typically an approach, I think, for referral center, for skull-based center. It's an approach you do 5, 6, 7, 8, 9, 10 year, or you should not do it. Because you cannot understand the concept and be comfortable with this anatomy if you don't practice it enough. So in this case, definitely, it's probably better to use a 𝒏𝒔. Is there such a huge difference between both techniques? This is hard to say. Tata Jiba, Majid Sami, they are strong advocates of the 𝒏𝒔 approach that they are using a lot, and they have excellent results also. So it's not so easy to tell. It's not black and white. You have to do what you are the most comfortable with. But if you want to build a strong skull-based practice dealing with a lot of those complex lesions, chordoma, chondrosarcoma, petroclival, I think it's good to have someone who is focused on this. It doesn't need to be the same person, but you need to have someone focused on those techniques. I have the good fortune to have a center where we have a lot of those cases. So combined petrosal, I would say I do probably around 2 cases a month. So it's a lot. So it provides you experience, and it provides you also the ability to push forward the technique, to change it, to modify it, to learn from each technique to improve the next step. But if what I do can benefit to young guys who want to start into it, I think it's a valuable option. About endoscopic endonasal, I am not an advocate of meningioma through the nose because of the risk of CSF leakage. And I am not an advocate of taking out big intradural lesion through the nose because of the risk of injury to cranial nerve. But I use it sometimes. I think an extremely good indication, it's jugular tubercle meningioma. Takeo Goto has published also on this, and I think it's a very good indication because it's very straightforward to the jugular tubercle, and the lower cranial nerve are lateral, so you come from the good direction. But also on clival meningioma also, but this is very rare, pure clival. So yes, I think it's retrocede is the first, combined petrosal comes second, but to use combined petrosal, yes, you need to have someone dedicated into it, dedicated to do it and to do it often.
Thank you, and thank you very much.
If may I ask something, Prof?
Yes, absolutely.
Thank you. First of all, let me thank you for this wonderful lecture, and it was an amazing teaching sessions, and you have been doing great webinars in the past also. You have recorded this on the 𝒂𝒑 YouTube channel, and there are around 1,700 views, out of which 700 will be only mine. That is one of my favorite videos about posterior petrosal. I have also been fortunate to assist Prof. Takeo Goto in this 1 or 2 cases while on workshops, and startling differences between him and your approach is he puts a lot of emphasis on the emissary vein. On the first burhole is always on the emissary vein, and then you dissect the sinus from superior to inferior. So that is one. And another, the craniotomy, the facial flap, your incision is from posterior to anterior. His incision is from anterior to posterior, and the flap of facial flap is based on the sternocleidomastoid, and they preserve this flap to cover the defect at the end of the procedure. And third is the preservation of endolymphatic sac that you showed, whereas they always cut it. So I don't know what is there any definite advantage over preserving the endolymphatic sac. And other thing is the localization of the GSPN with always they use the facial nerve monitor to map the GSPN before cutting. And also the cutting of the superior petrosal sinus is way anterior, much anterior than where you showed. You cut it much closer to the junction. So these are differences that I noted in this. I just wanted to know, to ask you if there is any specific advantage or preservation of an endolymphatic sac.
So for the endolymphatic sac, I absolutely cannot answer your question. I have no idea. But I have the feeling that if you preserve it, at least you don't need to ask yourself the question. So there is a lot of reason for hearing to be lost in a combined petrosal. Opening the middle ear, having otitis media, injury to the cochlear nerve, injury to the cochlea. So my point is maybe we should not add, and there is ENT who say that if you cut the endolymphatic sac, you may lose some hearing. So I prefer to keep it because I have no need to sacrifice it. So if you have to sacrifice it, then yes, it's a question to ask yourself. But if you don't need the technique, I am not the one who found the technique. It was my research fellow who did it in the lab, and I thought that's very clever. And I did it in the OR. And now we do it systematically. But if I have to struggle because I cannot do this technique, and yes, at the end, I cut the endolymphatic sac. But in the last 10 cases we have done, I was, I think, able to preserve it. About the difference with Takeo Goto, I will think about it carefully, what you said. One major difference is that at some point he do the anterior petrosal approach intradurally. which means he opens the dura, and after opening the dura, he drills the petrous apex. This to me is, I personally don't like it, because drilling intradurally is always an additional risk for the structures. That's, I think, the main difference between us. But both techniques, you know, are quite equivalent. At the end, the goal is to drill and to dissect and to mobilize only the structure you need to dissect, mobilize for this specific target. That's the point. Before, I was doing a big C-shape incision, same approach for everyone. But for a significant number of patients, some of the steps I was doing were useless. And you cannot do useless thing in such an important approach. You know, it's a shock for the patient. So every economy you can make for the patient healing or recovery, it's a benefit for him. That's the idea behind all this.
Thank you. Thank you very much.
Thank
Thanks
you.
to your question.
Any other question? Okay. So, Professor Froelich, thank you for a beautiful lecture and a wonderful lecture. And I was impressed about your chopstick technique. And today I learned the stabilization of the endoscope by wet sponges just inside the craniotomy you place?
No, outside, all around, outside. You know, when you do a retrosig, you put wet sponges all around, and you can support your endoscope.
Yeah.
It's very simple. Water and sponges.
Nobody knows how to do it. So yeah, it was really impressed. Okay. Thank you.
Thank you very much.
Yeah, I always remember the talk we had when we met about the old movies. You like old movies, like Jean-Luc Godard and some Japanese movies. Yeah,
absolutely.
I'm looking forward to seeing you again in the future. Thank you.
Bye-bye. Thank you very much. It was a great discussion. Thanks to you. Bye-bye.
Okay. Shall we move to the next speaker?
Yes, please.
Okay. So next speaker is sorry, I have lost
Dr. Milan Lepic.
Dr. Milan Lepic.
Dr. Milan Lepic from Serbia.
Yes, he's here.
Okay. Are you ready for the presentation? No? He's not here?
Yeah, he's here. He's on the screen.
Oh, okay. Okay. Okay, so Dr. Lepic, will you start your lecture?
Milan, your audio is not there. We can't hear you, Milan. There is some issue with the microphone. No, we still cannot hear you. Maybe you can check which mic have you put. No, on the Zoom there is a mic, a symbol, and beside that there is a arrow. If you click that arrow, you will see many options. Select a microphone in which same as system. You can put it same as system. Did you see on the Zoom, on the microphone symbol, the first symbol down it is a mic.
Computer?
Yeah, now it's okay. Now we can hear you.
Okay, so I was using the AirPods, but it's not going well. So thank you, Boon.
Please share your screen again, please.
Thank you to Professor Kato for this kind invitation. And I'm Milan Lepic. I'm a neurosurgeon from the Clinic of Neurosurgery in the Military Medical Academy in Belgrade. It is Serbia, it's a small country in Europe, and our experience my field of expertise, let's say so, is management of chronic subdural hematomas. So it's not something that is even comparable to what Professor Štrovlik just presented, but I think it is still an issue for the young neurosurgeons, as I experience a lot of, I have seen a lot of wrong things done from my side, but also from our residents, from other colleagues who are young neurosurgeons who are usually doing this and managing these cases. So I would like to tell you a few things about it, basically on the evidence-based stuff on the management of chronic subdural. So I do not have anything to disclose. I'm a little biased on the endovascular management, as I don't encourage it in the management of chronic subdural hematomas, but it's probably going to be discussed later on. So regarding chronic subdural hematomas, it's sometimes called favorite neurosurgical entities. So I put this search just which was made just now. So it's more than 4,500 results in PubMed on this topic, and its first mention is 1927, and up to date in 2024, 170 publications were published in this year. So it's definitely very, very popular among researchers and those who are publishing. So it's one of the most common neurosurgical entities. It's something that young neurosurgeons usually come to at first. That's probably usually their first surgery that is performed on their own, and it is the most common neurosurgical emergency procedure. So incidence is rising. It is expected to double in the following 20 years, and this was said like 10 years ago, and it already got at halfway to the double, and it's still expected to double from this in next 20 years. And mortality is underestimated in these patients, and this is some other also very important point, is this is probably some kind of presentation of frailty, and I'll try to discuss this in the later on. So pathophysiology is quite updated from what I learned, let's say 10 to 5 years ago, when I was starting to deal with these patients in my young years. So it was thought that it's repeated trauma that is usually happening in old people who are unstable, and then in those who are abusing alcohol, where they hit their head lightly into some objects, which is making their vessels, venous vessels usually, bleed, and then it extends this blood collection. But nowadays it is quite well known that it's a combination of inflammation, trauma, then formation of a membrane, and then blood leakage that is caused by this inflammation, and that is happening in the membrane. And so it is probable that in the future, in the ICD-11 classification of diseases, it's going to be a separate entity, which is going to be either chronic subdural hematoma as per se, or it's going to be membrane-associated hematomas as the group, because acute and chronic rebleeding hematomas that are usually very, very good, very well treated, and with good outcomes even in those very old patients, is going to be sub-entity of this particular, I like to call it disease, not the trauma. So regarding epidemiology, it's 1 per 100,000 in 18 to 49 years old. Then it goes up to 7 in 50 to 60 years old, and 60 in 80 to 89 years old. So it's rising with age, and it's rising due to the availability of the diagnostics and all this availability of the neurosurgical treatment, which is like well available in Europe, and not so in Africa. It's probably going to increase a lot when Africa gets a lot of CTs and diagnostic possibilities. So regarding surgical management, symptoms related to CSDH are well known. It ranges from the benign headache and then goes to major symptoms like motor deficits and epilepsy. But usually patients who are with mild headache and with hematomas that are not big enough should be treated maybe conservatively or followed, because in those patients the introduction of drain may lead to some brain injury or bleeding that is more damaging than the chronic subdural hematoma itself. So overall, these patients who are having major symptoms should be treated, but there is no consensus or evidence to radiological cutoff. It's usually more than 10 millimeters in thickness and then more than 5 millimeters in midi-sagittal shift. Age alone should not be contraindication for surgery, and this is very important point, which differs from the majority of neurosurgical diseases. There are 7 main surgical aspects. It's anesthesia, whether to use local or general anesthesia, burr or twist drill versus craniotomy, mini or usual craniotomy, and why and how many burr holes should be done. Also, irrigation is controversial. Temperature of irrigation, closed drainage system, should it be placed and how long should it be left for? Then type of drainage, whether to do it subdural or subgaleal, to put the patient to bed rest or mobilize early, and then to use routine CT control after the surgery or not. So regarding anesthesia, the state is pretty clear here. There is class 1 evidence supporting the superiority of local anesthesia versus general anesthesia due to the significantly less complications related to anesthesia. The biggest problem is usually agitation, which is not present obviously in general anesthesia and happens in patients who are done under local anesthesia, but it is usually easily overcame. So also with the experience and doing the procedure properly, you are doing it in quite little time, so patient will usually be better during this short intervention. Regarding the opening, so there are 3 options, general 3 options: twist drill craniostomy, which is favored by the industry-made devices to make the procedure bed rest in bedside, and in general they are suffering to the more reoccurrences than the burr hole craniostomy. Burr hole craniostomy is usually the standard. It could be made with 1 or 2 burr holes, as depicted in this picture. It's 1 to 3 centimeters wide, but usually a single burr hole size is the standard, around 12 to 13 millimeters. Then the craniotomy, it could be mini craniotomy with opening of the dura and resection of the outer membrane, and this procedure is usually reserved for the reoccurrences. So class 1 evidence, although not significant, suggests the superiority of burr hole craniostomy over TDC and craniotomy in terms of reoperation. So this is very important to note that burr hole craniostomy is going to burr hole craniostomy treated chronic subdural is going to reoccur less often than that done with craniotomy, although you will remove the membranes or remove the majority of the hematoma. So it's also related to the novel understanding of pathophysiology. So there is no difference in mortality, morbidity, or recurrence between BHC and twist-drill craniotomy, but these studies, as I said before, are usually sponsored by the industry, as they are making these devices but so it should be taken with the grain of salt. And also craniotomy has significantly higher complications rate than Burckle craniostomy or TDC. So next question regarding opening is 1 or 2 bore holes, and there is class 1 evidence supporting by a meta-analysis suggesting this then difference in reoccurrence mortality or complications is better in 1 versus 2 bore holes. And this bore hole should usually be placed over the hematoma's highest thickness to avoid injury to the brain. And the third thing is probably the most controversial, irrigation. Recent Finnish trial that was published maybe 2 weeks ago suggested that it could not conclude that there is a difference between borehole drainage with or without irrigation, but the trial favors the use of subdural irrigation due to the usual understanding that it helps. So, but class 3 evidence suggests there is no impact of mortality, morbidity, or reoccurrence due to the introduction of the drain and irrigation itself. But irrigation temperature was related significantly to the superiorly to the irrigation done on room temperature. So there is definitely a question whether these studies performed in the trialing, whether to use irrigation or not, were probably using room temperature saline, and probably if they would do it with the 37, so warmed saline on the body warm temperature, it would probably lead to better results in irrigated patients. So probably the conclusion from all of this should be that patients should be irrigated, but that irrigation temperature should be higher than the room. So it should be so body warm saline should be used. Regarding placement of the drains, there is class 1 evidence in favor of closed drainage for 48 hours to decrease reoccurrence from 24 to 9% and 6 months mortality from 80% to 9%. So probably this mortality is mostly related to the reoccurrence to new surgery. So you should always keep in mind that reoccurrence done is not just the new chronic subdural hematoma surgery, but it's also related to prolonged staying in the hospital, which always is related to hospital complications, and especially in this vulnerable population, it could be even fatal to these patients. Also, there is class 1 evidence demonstrating that there is no difference in reoccurrence rate between 24 versus 48 drainage. So the drain should definitely be placed for 24 hours plus minus few hours to remove it after 1 day usually. And there are also other types of drains that could be used. In general, smart drain is used in Europe for this surgery, while in Japan, from what I've seen, there is a dedicated drain for chronic subdurals. People also use 𝒂𝒑 catheters with these big holes that are used for the EVD, which could also be useful and less traumatic probably to the brain. So the point of this is that the drain is safe to place. And there is also a technique where you squeeze the drain and put it into the subdural cavity without injuring the brain with the sharp or cut side of the drain. And after placing it for 24 hours, it's probably going to be enough for the hematoma to drain. Also, there is this controversy regarding superiostal or subdural placement of the drains, and the study with major study showed that there is no difference between placement of the drain subdurally or subgallally, but definitely there is tendency of neurosurgeons to place this drain subdurally, as they usually don't believe into subgallal placement. but in general, when dura is opened and capsule is injured, they should probably place the when coagulated as well, the superiostal drain would do the job, and also you can use vacuum aspiration in the subgaleal placement of the drain, so it's probably very good option. So these are the studies on the drain as well, which showed the superiority of superiostal placement. So regarding mobilization, this is usually something that was questionable 5 to 10 years ago. So there is now class 1 evidence that favors early mobilization for these patients, and I usually put their drains to their pockets and ask them to go to the toilet and walk normally with the drain if they can do it. It's not affecting reoccurrences, but it's definitely affecting other complications. Also, when I started, there was the tendency to use the flat bed without pillow to improve the drainage of this patient, but it was shown not to have any impact on this. Routine CT is something that was also debated, and there is class 1 evidence that you should not make a CT control after the drainage itself, as the outcome of your surgery is usually going to be independent from what you see on the first CT. So, and the first CT done early could lead to more reoperations that are redundant. So it's very important to note. On the other hand, if you want to see something or confirm that your drain is properly placed, that you have not injured anything with the drain, you should not think about reoccurrence based on the drain, based on the CT done between 1 or 2 days after the surgery. As in these images, you will usually see a lot of remaining chronic subdural with the membranes and stuff, which is going to probably disintegrate during the 1 month period, and you will not need surgery at all. So to sum up, local anesthesia and sedation is superior to general anesthesia. Burkle craniostomy is at least same to twist drill in terms of complications, but it is better in terms of reoccurrences. In burkle craniostomy, 1 burkle is at least same to boreholes, so 1 should be used. Role of irrigation is still unclear, but irrigation with body temperature is superior to irrigation with saline on room temperature, and also to no irrigation. Closed system drainage is favorable versus no drainage, and in closed system subdural drainage, 24 hours is usually enough. Superiostal drainage is at least similar in results to subdural drainage, while leaving the brain intact and not risking the injury to it. Early postoperative mobilization is important, and it will not impact the reoccurrence rate, and routine CT is not favored usually. So reoccurrence is usually present in 8 to 30% in different studies, complications in 0 to 25%, including infection, bleeding, stroke, and stuff. And surgical mortality is in up to 10%, but this is considered only in patients who are favored for who are followed for a month or something, or let's say short period following. But in patients who are followed for up to 2 years, about 40% mortality is present. So these patients are actually a vulnerable group, which could be treated with more care, let's say, and more social care to avoid their dying after this surgery, which is usually going well. And after patients recovered from the surgery, they will die from some other entities. So it's very important to follow them and to raise awareness about this, so to treat this as some kind of sentinel health event in order to help this patient properly. So also standard outcome reporting in CSDH is lacking. Also, there are some emerging therapies, including pharmacological, where dexamethasone is the most important thing. Middle meningeal artery embolization is recently very popular. There are 20 ongoing RCTs at clinicaltrials.gov. So this is very, very important to note that that this is something that is happening, but usually these patients who are symptomatic were not treated in these studies, and patients who have symptoms are definitely candidates for surgery. So if you middle meningeal artery embolization is actually a good option to prevent reoccurrences, and then it's also probably useful for the patients who are asymptomatic or with mild symptoms, but these patients would usually be good with observation only and maybe rehydration therapy. So with drinking more water, they would probably be treated well and without this quite expensive management. So in terms of my clinic, we're having a project which is assessing positioning and steroids as adjunct treatment, as we have recognized the pneumocephalus as something that is probably leading to more reoccurrences than when prevented. We have developed this sitting position for treatment under local anesthesia, which is also coping with the patient agitation that was also mentioned before. It's also convenient for the surgeon, as you can maneuver the head easily, and you can make the hole at the vertex of the patient to reduce this air ingress and also to access both sides. So this is vertex manipulation. I will just show you the image, which is showing this concept, and then bilateral access, which is completely straightforward from this position. And this is how airflow is managed in the different positions. So this is patient in our position on the first image. Then this is sitting position without flexion, and this is laying position. And also there are options which are usually performed to put the head to the side. Depending on the side, you will reduce. Depending on the extent of this maneuver, you would decrease the air ingress, and this is the positioning to prone, which is usually very complicated for the patients to handle during their local anesthesia surgery. So we usually avoid it. Loaded steroids are something that we use for the adjunct treatment of these patients after undergoing minimally invasive burr-hole craniostomy, and there is usually no additional morbidity or mortality, and it has positive impact on the treatment outcomes in terms of reoccurrence. So we treat patients who have more than 50% remaining hematoma after surgery. We give them steroids in small doses, so they usually get less recurrences. So we have 9 to 2 in this 60 patients group. So it's still undergoing, study is still undergoing. So I'll probably come up with more relevant results in the future. So to conclude, it is the most frequent neurosurgical emergency procedure, and although the evidence is improving, a high level of clinical evidence is lacking for parts of the surgical management. But this is also, let's say, at least among the most defined procedures in neurosurgery. So there are no many spaces open to interpret the surgery difference. So you should definitely do the borehole, you should put the drain, you should leave the drain for 24 hours. You should not do anything based on the first CT. And you could put the drain superiostally if you are not afraid that it will make any impact. So definitely there is still place for improvement of this, but it's, as I said previously, it's probably the most defined surgical procedure in neurosurgery, and more research and standardized reporting outcomes is needed for this field in terms of recognizing this excess mortality and cope with it in the future. So I would like to mention 𝒂𝒂, this an international collaborative research initiative for CSDH. It aims to achieve this through reaching consensus on core outcome set, standardized outcome reporting, definition of CSDH, and data elements that should be used in the study. There, for now, this initiative has made some publications that could be used for the future publications, but I've not seen it completely followed. Although all the major CSDH researchers were probably involved in this initiative. Next thing, I would like to invite you to publish with us Neurochirurgia, the Serbian Journal of Neurosurgery, recently launched, maybe for 4 years now. So you can, if you want to sacrifice some publication that was not successful in other journals, it could probably get accepted in our journal. Thank you very much.
Thank you, Dr. Lepik. And thank you for summarizing the many ideas and evidences. Actually, I learned a lot today. There's many reports about the chronic subdural hematoma. And yeah, some of them are really interesting. The sitting position surgery, that was impressive. So after you learn a lot from the papers, so what is your strategy now? What do you think the strategy? What is the best, like drainage? Do you drainage? Or
for my department and me personally, I do everything like presented in the summary slide. So we do everything except that we do CT after the surgery to define whether we should use steroids in adjunction to this to the surgery, and everything else is done same.
Okay. On which side do you place the drain? The tip of the drain is upside or downside? So I mean, what do you drainage? The air or the liquid?
We put the drain posteriorly, so posteriorly, and then put it to the lower parts. But this has some impact on the accumulation of air. But usually, if you perform it in this sitting position with head flexed, when the borehole is at the vertex of the head, it will maybe not completely, but it will make minimal pneumocephalus in the subdural cavity, and it will usually be enough for the further treatment. So in Japan, you have this dedicated draining systems, and we are trying to make similar to it with the use of urinary bags.
Yes.
Which we place, so they don't have air inside when they are open. So it's in general a good option to do it in the sitting position and with head flexed.
Okay. Raja, do you have a question?
Yes, Sensei, thank you very much. First of all, Milan, congratulations for this wonderful presentation. I would just want to say a few things about your wonderful presentation. You said you routinely use steroids, and after the 𝒂𝒏𝒔 study,
yeah, I can explain that.
We have shown it that they have recommended not to use steroids because it has much unfavorable results than recurrences. Recurrences are less, but there are larger number of unfavorable outcomes.
So
one more thing, I'll just tell you. The other drug which is very useful is tranexamic acid. Have you tried it? The use of tranexamic acid?
We don't use it.
Okay.
Anesthesia.
We have
So-
used a lot of tranexamic acid. The current largest study I had published in 2000.
Okay.
And
Okay.
it has shown very good results. I recommend you try it and find out the results. It's very promising drug. And one more thing about the sitting position and surgery, the thing will be you will not be able to keep a saline. Do you feel saline during the closure? Because
Yes.
the air which remains will be a cause for headache in the post-operative period. So
Yeah, but there will be nowhere. Yes, that's the point is to close it immediately and not let. If you are keeping the head, as I mentioned, if you keep it flexed, so you put the borehole on the parieto-posterior sides, you will not have a lot of air ingress. So only brain pulsations, what they make will remove the fluid, and it will be very little air, which will leave as it's still on the top. So the air has tendency to go to the top, and you fill it with saline, and the air is actually leaving the head and not the fluid. So it is in general okay option. And the other thing regarding the steroids, so tranexamic acid is actually handling the bleeding from the bridging veins, which is at that moment. And as we all know, chronic subdural hematoma is drainable, so it's not actually accumulation of blood. It's liquid that is not coagulating. So that's why the whole procedure works with drainage. Otherwise, if it was a hematoma, it would occlude the drain. So I'm not sure about tranexamic acid. I'm not sure to understand how
I recommend you
probably
try
explain
it
it
because we have
probably
wonderful
explain it,
results.
and I believe it's useful, but we have to understand the pathophysiology and what we liked about dexamethasone, and it's reducing inflammation, and that's it actually resolving capsule, because capsule is the actual problem, and the fluid accumulation is solved with drainage. So we decided to use dexamethasone, but in low doses, as in DEX-TSDH trial, about 250 grams of dexamethasone were given. And in our style, we are using around 50 grams. So it's a lot less steroids, and we are only aiming to to reduce the risk of reoccurrence in patients who have 50% or less of hematoma amount drained. So I'm not sure whether it's useful. There are some patients, of course, who have issues with the blood pressure, with glucose, with excess glucose due to this use, especially those who are very frail and old. So I'm not sure whether it's going to be shown to be better, but definitely it has impact on reoccurrence. So we should probably think about the dose and maybe add also tranexamic during the irrigation, and then do a little dexamethasone for maybe a few days only, and it would probably be the proper treatment. Something in between.
Thank you. Thank you very much.
Thank you.
Okay, Dr. Aniak. Dr. Aniak, do you have a question?
Yes, sir.
Yes,
Yeah,
please.
thank you so much. Yes, sir. Thank you so much, Dr. Milan Lepid, for this presentation. As you said, chronic subdural it falls within these young neurosurgeons procedures. In this part of the world, in Nigeria, yes, it's good to know that this your lecture, this your presentation is as educating as it's informative. We irrigate. First of all, in anesthesia, yeah, some people were advocating for general anesthesia. Yeah, but it's been found out that, as you rightly said, that local anesthesia is better than the general anesthesia. Yeah. So here we are adopting the local anesthesia. Okay, and then in the boreholes, most of our cases we use borehole. However, we use craniotomy in some chronic subdural that's multiloculated. Yes, sir. Multiloculated chronic subdural is noted that if we use borehole, most of the times the recurrent rate is high. So we adopt chronic subdural where we identify multiloculation in the cavity. Yes, irrigation, the temperature here is different from the temperature in the temperate world. Here, equally, we try to use warm saline for irrigation. This hinges on creating the normal body temperature, not really for any reason, but just creating the normal body temperature for the brain. We believe that using cold saline on the brain is not good, it's not fair. Then the drain is important to know in this presentation that the draining for 24 hours and 48 hours is comparable. Yeah, here sometimes we keep the drain for 72 hours, so it's even baseless keeping the drain beyond 48 hours. So this is very, very important to us. Mobilization, here we used to keep the patient in bed for a long time. On the it reduced reoccurrence. But here you can see early mobilization, which is very, very important. You can see the incidence is commoner in older people. And then keeping older people longer in bed predisposes them to some complications like even deep vein thrombosis and all that. So it's important to know that early mobilization is good in this patient. Now we have rising incidence of chronic subdural. Why do you think you have this rising incidence? Is it that the cases is it real or apparent? Is it that the cases are now more reported, or that we are really having more chronic subdural? What do you think, sir? Is it that the cases are now reported more, or that we are really having more chronic subdural? So thank you so much for this presentation.
Thank you very much for the question. I personally believe that, as with all other diseases, it's probably more frequently diagnosed, and
Okay.
maybe it's increasing with the age of global age of population, but in general, I think it's more related to availability of CT, and that everyone can do it CT whenever he wants to. So it's probably more important. And I want to point one more thing that you mentioned. So these pseudomembranous chronic subdurals, where you have septated type.
Yes.
So it was
Yes.
a long time ago. It was recognized by Nakaguchi that it is very last phase of the development of chronic subdural. So it's the phase where the organism, let's say, so body has started to battle with the chronic subdural. So it made all these trabecules who are going to absorb the liquid and resolve the chronic subdural. Unfortunately, this does not happen because you don't have enough space, and this process is probably very slow. But if you do the drainage for these patients, you will usually resolve their symptoms, and they will have this residual mass that is mostly trabecules with some liquid captured, but in general, reoccurrence is less common in these patients. So borehole drainage is usually enough to do for them, and let's say craniotomy is usually over treatment, although it's related to less reoccurrences, because if you do this in this patient, you are removing the more liquid, and the body has less to do with removing with the trabecules. So it's something that is like unbelievable, but shown in the studies as well. So it was also something that I was doing previously. Then I switched to doing only borehole and drain for 24 hours, and after symptoms are resolved, they have this mass that is remaining, but in 1 month it is already squishing to almost nothing. So I believe that craniotomy should be only reserved for those patients who have acute rebleeding in the chronic subdural.
Okay, interesting. All right. Thank you so much. Thank you so much, sir.
Thank you for emphasizing this. Thank you.
Dr. Bishwas, do you have further comments? Do you have?
Yeah, Sensei, very excellent presentation and very thorough research work. Actually, after coming from Fujita, what we practice, Sensei, right now is if it is a multiloculated chronic subdural, we take the endoscope and with malleable sucker, and we try to take out the outer membrane especially. We don't manipulate the inner membrane, and we keep the subdural drain. By this way, we can reduce the recurrence. And as the presenter said, he is a bit biased to endovascular treatment. I just wanted to know what is their institutional protocol to go for the endovascular treatment in chronic subdural hematoma.
In our institution, it's none. So nobody is undergoing this. We are like a poor country, let's say. So treatment with embolizing, so which demands onyx. Recently, you have to use very expensive embolizing substance, and also catheters and stuff, and you can do it almost free with just one borehole. So you can use single use or bore piece, and that's all. So in general, that's what we do. But there was also some study from the Turkish group who did another borehole at the origin of the middle meningeal artery. So they just put the borehole there and coagulated it, and it probably same effect. So
okay. The financial status of patient and their will nowadays has to be respected. And patient often, or their attendant often come with a background knowledge regarding the endovascular treatment. So what we do in first case with symptomatic chronic subdural hematoma, if there is no patient choice, we go with one borehole and 2 irrigation drain with 6 or 8 French NG tube, feeding tube, 6 or 8 French feeding tube at the same time put in a opposite direction, and we try to give wash with one feeding tube, and the saline comes out with another feeding tube, and lastly we give a subdural or subgaleal drain. But there are a few patients who come with recurrence. In that case, we evacuate, but we send the membrane for histopathology. And depending on the histopathological membrane, it is 4 types. One is non-inflammatory, another one is inflammatory, another one is hemorrhagic inflammatory, and another one is fibrotic type. The second and third type, that means the inflammatory and hemorrhagic inflammatory type histopathology, they have a high risk of recurrence. So in those cases, we try to, if financial status suffices, we go for drainage at the same time endovascular treatment.
Okay, and you take material for pathology every time you do the.
If in first surgery, if it is depending on the CT scan, we don't have MRI, we do have the CT scan. If it is on surgery, if it is thick membrane, we take the membrane for histopathology.
So on reoccurrences, you take the membrane.
And in case in first surgery we didn't take the membrane, but in recurrence we take the membrane.
Okay. In general, that is probably the way to go. It's individualized, and the most important thing is that if it is inflammatory membrane, and it's usual experience from every one of us. If there is acute subdural hematoma which has went to chronic phase, it's never going to reoccur because it's not related to this procedure and probably not related to this entity we are talking about. So.
And subdural drain and dexamethasone, it has also been suggested to use depending on the glycemic index of the patient and the blood pressure of the patient. Thank you.
Yeah, thank you. Thank you.
And thank you for the discussion. Because of the time, I would like to proceed the meeting. Okay. Thank you, Dr. Lepik.
Thank you. Thank you.
Nice presentation. And I'm going to invite the last speaker, Dr. Pham from China.
I'm from Vietnam, actually.
Okay, you are here. Are you ready? Okay. Okay, will you start your lecture?
Yes. Could you see my screen now?
Yes, I can.
Okay. Thank you very much for Professor Kato for giving me the opportunity to present in this webinar. My name is Huy Pham. I'm a current fellow at Fujita Health University Hospital. My main workplace is Viet Hospital in Hanoi, Vietnam. And today I'm going to present to you a case of GSPN schwannoma and that requires emergency surgical resections. So our case was a 52-year-old female patient without comorbidity. She came to a primary medical center with the chief complaint of memory decline for around 9 months, and she was referred to our hospital. On clinical examination, she was awake, but impaired cognitive function would be recognized. No other neurological abnormalities was found. We indicated patient for higher neurological function. And this is the pre-operative MRI that was taken in the previous hospital. It saw a very large lesion in the left middle fossa with heterogeneous contrast enhancement. You can see the lesion also caused some erosion at the patient's bone. And there's also some abnormality in the mastoid cells as well, but it's not enhanced in the T1 contrast. And also there is hyperostosis in there. So it was interpreted as another abnormality not related to the tumors. The mass effects also significant that caused some herniation with the anchors compressing the brainstem. The patient was hospitalized on the same day. And as I mentioned before, the patient was indicated for higher brain function to evaluate the cognitive function, also for re-MRI and for CT scan to evaluate the bones as well. But on the second day of hospitalization, the patient started vomiting, and then she fell into coma with dilated left pupil. This is the emergency CT that was taken after that. You can see the lesion is similar to the previous MRI without hemorrhage, without progressive edema. The ventricles are near the same. So we think the cause of coma might be related to the brain herniations, not compressing the brainstem. And the patient was rushed into the operating room for surgical resection. This is the video of the surgery. The patient was operated by intradural subtemporal cranial approach, and the temporal craniotomy was performed, and we opened the dura. This is the temporal blood on the left side. This is the dura of the temporal fossa, and now we try to expose that. Because of the urgent emergency of the patient, we did the aspiration of the cystic to decompress the brains, and the fluid was in yellow with And then we dissect the lesions, the dura and the capsule. We open the tumor. The tumor is composed of different components with some yellow tissue with a little vascularization. And we remove the tumor in a piecemeal fashion. The tumor is soft, so it make the resections easy. We also use ultrasonic aspirators during the surgeries as well. Of course, the intraoperative neuromonitoring was used to navigate the GSPN and geniculate ganglion. And in this, you can see this is the erosion point of the petrous bone. And after the tumor was removed, we had to leave a little membrane along the GSPN that was found to be associated with the lesions. And this is the final view. There was a minimal injury to the temporal lobe. And after the surgery, the histology showed the lesion was schwannoma, and the patient regained consciousness after 4 days in the ICU. But still, the patient has impaired cognitive function, and it was evaluated with Wechsler intelligence scale, and also memory functions as well. It's so impairment. Additionally, the patient developed left facial palsy that is grade 5 on House-Bragman scale, and it might be because of the retraction of the GSPN. And this is the post-op MRI 2 weeks after the surgery that show no enhanced residual. The brainstem was free from the herniation and the compression of the tumor. And this is 1 year follow-up. The patient was able to return to work, and the facial palsy will improve to House-Bragman grade 3. And this is the MRI that was similar to the one that taken 2 weeks after surgery. There was some CSF collection of fluid here, but there seemed to be there's no recurrence after 1 year. And the cognitive function also show a dramatic recovery in terms of intelligence and also the memory scores as well. So literature review and discussion. GSPN schwannoma was a benign tumor histologically. It could be included in a group of facial nerve schwannoma. It constitutes around 0.8% of intertemporal bone tumors. But most of the facial nerve schwannoma occurs in the geniculate and the labyrinthine segment, not the GSPN. So GSPN schwannoma is very rare, and there were less than 30 cases of that reported in the English literature. So this is the summary of the case reported that I searched on the Medline. That the lesion occur with higher predilection to female, and this can occur at any age from 23 to 65. Regarding the relationship between anatomy and diagnosis, as you know, GSPN is a continuum of nerve intermediates from the geniculate ganglion, and it's caused along the middle fossa to the lacerum foramen and continuous video nerve that comprise mostly the sympathetic nerve fiber and this synapse, the pterygoparotid ganglion, and finally innervate the lacrimal gland and nasal cavity. So injury to the GSPN would cause xerophthalmia, which means dry eyes. The most common symptoms that were reported includes xerophthalmia, hearing loss, because of the destruction into the tympanic cavity by the tumor, and the facial palsy because of the involvement of the geniculate ganglion mostly. The pathonormatic radiological sign to diagnose GSPN schwannoma is the erosion of the anteromedial patient bone. So there are different diagnoses that we have to take into account for the cystic lesion in the middle fossa. The first one is trigeminal schwannoma that is more popular than GSPN. But this lesion often present with trigeminal nerve function symptoms, especially trigeminal neuralgia, and the erosion of the bone is more medial to the macrocaph and to the petroclival junctions. And the cystic meningioma is a rare lesion, and that appears cystic as well, but we can differentiate that as with the tail sign. And also, as you know, meningioma is more associated with hyperostosis rather than bone destruction. The other cystic lesions that are interaxial might be considered as a differential diagnosis are pilocytic astrocytoma, pleomorphic centroastrocytoma, but they are tend to infiltrate along the white matter tract rather than a bud on the skull base like our case. So our case was diagnosed as GSPN schwannoma based on the clinical symptom and the radiological signs, and also the findings of the association between the tumor and the GSPN. For the relationship between anatomy and surgical approach, the GSPN is located in the interdural space within the periosteal dura. So there are two main approaches that you can tackle this lesion. The one is intradural subtemporal approach that was used in our case, and the other approach that is that gain more popularity is extradural subtemporal approach that is somehow similar to Kawase approach that you can peel up on the temporal dura and tackle the GSPN afterwards. So there are advantages and disadvantages between two approaches. The intradural subtemporal approach that could allow you to access early to the tumor, and especially in our case that requires urgent decompression. So that was employed in our case. But this poses more risk to GSPN, ICA, xenonuclear ganglion, because we can find those structure in the end of surgery when we remove the tumor. And in our case, we have to leave a little membrane over it to avoid injuries. And of course, there is more parenchymal injury to the temporal lobe. But for extradural subtemporal approach, it can avoid direct brain retractions. It allows early identify anatomical landmarks, including geniculate ganglion, GSPN, ICA, but it requires skull-based expertise that not really available in the emergency situation sometimes. The endoscopic adenoiser approach was reported for 2 cases by Chinese author, and it's offer good outcome as well. Radiosurgery was used for, as you know, for schwannoma of different nerves. But maybe because of the rarity of GSPN schwannoma and also the advancement of microsurgical techniques, it's not used or it's not reported in the literature. But I think it might be an alternative for some small lesions, and also we have to consider the patient desire and the symptoms as well. So in conclusion, GSPN schwannoma is an extremely rare lesion, and it can be diagnosed preoperatively by clinical radiological features. Despite being histologically benign, a large tumor should be operated as soon as possible to avoid exacerbation of clinical symptoms. Thank you very much for your attention. This is some references that you can refer to.
Thank you, Dr. Pham, for presentation about the rare case of GSPN schwannoma. And any question about this presentation? Actually, I couldn't find the bony erosion at the petrous bone in this case. So most of the tumor is inside the temporal lobe, and the petrous bone was not so much infiltrated. How about the intraoperative, erosion? Did you find any break of a bone?
Yeah. Because of the emergency CT, the CT was undertaken in the emergency situation, so I couldn't retrieve the bone window for the CT scan. But you can see some erosion on that CT and MRIs as well regarding the relationship between the tumor and the bone. Additionally, during the surgery, we found the erosion of the anterior medial portion of the patient's bone.
Okay. Okay. Any question?
Maybe any comment from Professor Constantine?
Well, thank you for finally I can appear. Now, I would like just to say that maybe after the procedure, better to do thin slice imaging, because there might be some residual parts still in the petrous bone backwards from the geniculate ganglion and related to the facial nerve. So that might be a source of recurrence. No, I don't have any other comments. Otherwise, a rare, interesting case, and thanks to the presenter. It was a very nice one.
Thank you very much for the comments.
Dr. Lepik, do you have a question?
Yeah, I wanted to say it's quite an amazing case, as I have never before and never seen it for many for a few recent meetings. How many of such cases have you treated to time?
For a GSP and schwannoma.
Can you hear me? Yeah, particularly GSP and schwannoma.
This is the first case that I encounter. But I think there are cases that we might misdiagnose during our practice as well. In our hospital, is the this case is actually from Japan, actually, and for example, in my hospital, is a largest surgical center in Vietnam, and it can operate around 6,000 elective surgical neurosurgical cases per year, and I believe that there have been some GSP and schwannoma that might be misdiagnosed in my departments as well, and somewhere else.
Yeah, but in your department that is treating so many patients, it's, you have never seen it. That's
yeah.
It could be misdiagnosed, but it's very, very impressive. Thank you. Thank you.
Yeah, thank you.
Any other question? Okay. Okay, thank you for the presentation. The rare case. Yeah. Okay. So maybe it's time to close this session, Dr. Ben.
Today we have a very educational and very long section for today. And first of all, I'd like to thank you, Professor Watanabe Sensei, for chairing this section. It's highly educational, and I would like to thank all the speakers for joining us today, and also all the discussants, and also all the moderators today. And it's a huge success for today's webinar with more than 1,000 views over YouTube and also the WeChat channels. And on behalf of the Educational Committee of ACNS, I would like to thank all of you, and I hope that to see all of you in the next ACNS one as webinars. So it's the end of today's section, and I would like to say goodbye to all of you, and thank you so much for joining today. Hope to see you next time. Thank you.
Thank you.
Thank you.
Bye.
Thank you. Thank you. Bye.
Bye.
Bye.